Thank you, Chairman. And my teacher for interventional treatment for AVM is Professor Murray and Salu. So I come from Huashan Hospital. So last year we have more than 18,000 cases in our hospital. This is our new campus. So now we totally have 4 campuses. So last year I moved my personal serial bypass more than 1,000, and interventional treatment is 197. AVM is 47. So it's only a small part of my work. So now totally we have 800 beds and 40 operating rooms. So when you go to the operating room, you have to check which number is your room, just in the airport. So the problem in AVM treatment is that open surgery belongs to the neurosurgical department, and the embolization belongs to radiology department. Gamma knife and the cyber knife belongs to radio surgery department. So there's poor communication among the specialists. But in our hospital, all the specialists belong to the neurosurgery department. So the open surgery and the embolization could be treated by the same neurosurgeon. We have 3 neurosurgeons can do this hybrid treatment. The embolization for hairpin open surgery or radial surgery was different with that for curing by single way. And the cyber knife and the gamma knife was well known by neurosurgeons because all the neurosurgeons would go to this subspecialty for 3 months. So this is our strategy for the AVM different size. If the volume was less than 10 centimeter, we will use gamma knife, and if it's larger, we will prefer to choose the cyber knife. So high risks in the angio architecture in DSA, including small size, exclusive deep venous drainage, deep location, and the posterior fossa location, and the association with aneurysm or venous ectasia. So the patient who pose all 3 high risk characters, the annual hemorrhage rate was quite high, almost 1/3. So this is a high flow fistula and aneurysms. This is a venous ectasia and the stenosis of the draining vein. So we can achieve the better result by hybrid treatments. So preoperative functional MRI, intraoperative ICG or angiogram, combination of the preoperative partial embolization and the surgical resection in hybrid operating room. Now we have 3 hybrid operating rooms. And the neurosurgeon who can make the individualized hybrid surgical plan according to the special vascular architecture and the hemodynamic changes. So this is assisted partial embolization. We can see the goal is to control the deep feeders or the feeder attached to the main draining vein. So it's unnecessary to let the embolic substance like onyx feed the nidus a lot. So the hemodynamic change is not as dramatic as that in the therapeutic embolization. So the reflux of onyx, which is normally inevitable in therapeutic embolization, is also unnecessary. So the retreatment of the microcatheter is very safe. Normally, we will perform the resection at the same day or on the second day. So actually, the embolization onyx give us some landmarks to find the deep feeders. So this, with the help of the preoperative embolization, the resection procedure would even safe and easier. In the no eloquent and eloquent area, we can use preoperative MRI, and in the operation we can achieve very good result. So in our hospital, we have a long history for the resection until 1970. 17, we have 873 AVMs, including 402 low grades, 184 middle grade, and 287 high grade AVMs. Totally, the rate of morbidity and mortality was quite low. So the cure rate is 98.7%. So for the single cure embolization, the cure rate in our hospital was was not very high. It's only about 20%. So this is AVM grade 1 was cured by onyx embolization. This is a grade 4 partial embolization. Then with further treatment, resection. So onyx embolization cured, we have 463. We should have more cases, but because of the market reason, there's maybe 4 years the onyx was stopped to supply in the Chinese market. So actually the number was very not very so high as a resection. So this is our result. We have 5 patients died. So gamma knife, and this is our gamma knife. This is the 4 generations gamma knife in our hospital. Normally we will treat the nidus less than 10 milliliter. And this is, we also have the latest cyber knife. This is already the formal model. Now we have the even new model. So let's see take a glance of the result. This is a pre-gamma knife, and after the gamma knife 3 years, we can see the AVM was totally cured. And this is a grade 2 or 3 because this is in the functional area. The AVM was gone. Actually, the interesting thing is after the AVM shrinked, the cortex was recovered totally. So this is our result for embolization on the gamma knife. So this data was still stopped at the 2014. From then, the supply of the onyx was stopped. So we have 86 cases. And this is the final result. We can see the cure rate is in the combination is 76.7%. It's higher than the 64.7% in the reported. This is a cyber knife. We can see after the 2 years treatment, the cyber knife was cured, the AVM was cured. And even larger cerebellum AVM, we can see after 3 years, this AVM was larger than 10 milliliter. So it's also the draining vein is deep. So we use this cyber knife. After 3 years, you can see totally cured. And this is even larger, almost half of the cerebellum. After partial embolization and treat of the cyberknife. So 3 years, you can see it's totally cured. Same results. So cyberknife, we treated 274 cases, 173 after embolization. Total cure rate was 78% after 3 years. So the low grade can achieve 91%. The higher grade, the cure rate was 83%. So the combined treatment makes the risk for AVM much lower than reported by single treat strategy and the natural history. So in our series, the complication rate is only 1.83. Thank you. Any question?
Question?
Okay.
Thank you very much. This was a very nice presentation. If I understood you correctly, so if you would have a deep-seated AVM that has ruptured, for example, in the basal ganglia or thalamus, so you would partially embolize that and then go for, depending on the size of the AVM, for a gamma knife or a cyber knife.
Yes.
Is that correct? And so my question then is, so you trust or rely on the effect of the partial embolization that there won't be a rebleed. So how much, or how do you decide how extensive your embolization
Actually, if it's
an
emergency AVM case, small nidus, we prefer to wait for 3 months. After that, we will do the embolization because we consider that strategy is more safer. Yeah. After the absorption of the hematoma.
Yeah, but also my question is, how do you know how effective how the protection of a rebleed is with your partial embolization? How do you choose how the extent of embolization?
I beg your pardon.
So you do a partial embolization, huh?
Yes, for this, we will treat the main feeder. Yeah.
Thanks a lot. I remember that 20 years ago, there was maybe 2 or 3 teams all around China doing this business. Look at what's happening today. It's a wonderful evolution. You not only got the institution, the environment, but you also got the number of doctors and the training and everything. And over a period of 20 years, it's a tremendous evolution. So congratulations for this. I'm sure you are not responsible, honestly, but you know, the whole country has changed dramatically, and we definitely have to think about this. And it makes a point which is, for me, very interesting. You are a major player in terms of activities, and now you have a lot of experience too at the same time. So you could probably play a big role in a new study to better understand what kind of treatment we should apply for brain AVM. Because we know everybody has its own recipe to treat an AVM, but if it was possible to build up a strategy with a large consensus for the treatment of AVM, it would be definitely better for our patients. So I honestly think that we know how to treat AVM. We know much better how to manage AVM for a permanent cure, but we don't know exactly what is the good sequence of strategy. So it's our duty to think about having a study which is trying to clearly establish this kind of evolution. You know, there are 2 big directions for the time being. We know for now 12 years or 15 years, maybe 12 years, that we have to occlude the vein, and we have a lot of data to prove that the key is the occlusion of the venous system. What we don't know is it better in terms of clinical result for the patient to do it only by one single treatment, gamma knife, surgery, endovascular, or if it's better to start with one, continue with the other one. I'm not saying that we should definitely manipulate all the different kind of treatment for the treatment of all the patients, but maybe the combination of two might be a good way to do it. So thinking about having, for example, endovascular surgery, endovascular radiation, a study which is clearly establishing that it's better or it's worse to do this kind of combination. We do a lot of AVM. We go most of the time from endovascular, and we go for cure of the AVM. We have good results, anatomically speaking. We have acceptable results, clinically speaking. Is it better to have a combined treatment to improve the clinical result for the patient? And this is really our, to me, the purpose of the coming out years. You know, when you get older and when you look at all the mistakes you have done in your career, you really think that it's good to think about improving what we are doing for the best of the patient. And it doesn't mean that it's only through your hands. You know, a team approach with multiple techniques might be a good way to do it. And AVM is probably the way to do this. So I'm not going to initiate a study like that, but I really push to try to force the younger people to start these kind of studies. You know, for example, a selective grade AVM, 1-2. Is it better to do it surgically or endovascularly or having a combined treatment? For the time being, we don't know. Aruba doesn't answer the question. BAT doesn't answer the question. TOBAS, according to the structure of the study, will not answer the question. The study should be randomized and stratified. It's not that difficult to do it. It's not that difficult. So having money coming from government, not from companies, coming from government, should be a way to improve really our result.
Yes.
And I'm not too much fascinated by the technique today because, you know, we are doing the same thing for the last 7 years. Every single patient you treat today is treated the same way as we were treating 7 years ago. 7 years ago came on the market the web. Since that, nothing new. So we have to really understand that for the last 7 years, we do exactly the same business. It has never happened to me, to him, to her, despite the fact that she's much younger, but it has never happened to us, doing the same thing for at least 6 years. No change. So the only change can come from understanding strategy and this kind of study to improve and have a consensus on the way to treat those patients. Honestly, you don't foresee any big evolution. Everybody knows what's going to happen in the 5 years. We cannot probably foresee more than over 5 years. Robotic is just a tool to add to what we already do. It's fascinating. A lot of people will jump on it, but it will not change dramatically the situation. So honestly, for the 5 years coming, it will be 11 years in a row without real modification. So we really have to tune in a better way the indication. What do you think?
Yeah, Professor,
forget about technique, forget about, you know, this recipe, a little bit, a drop of this, 2 drops of that, 3 drops of this. You know, who cares about that?
Yeah.
Who cares? You know, I prefer to put a web, I prefer to put a stent and call it shit. Show it that it's better. Yeah. You know, we cannot continue this way.
Why not? Yeah. Talking to the AVM, you know, for me, I think the resection is just like the Air Force. They throw big bombs and make the field totally ruined, including the surgeons and all the soils was all ruined. And for the embolization, it's like a tank. It can be through different direction. He can ruin the opponents. And for the radio, for the gamma knife or saga knife, it's just like snipers. It's slow, but it can be occlude very small feeders. Yeah, so we can use combined.
I was ready to say exactly that. Maybe instead of speaking about Air Force and sniper and diplomacy is also a way to go. Fortunately, you didn't use Air Force One. So.
Okay, thank you.
No, thank you.
My question is really, you have 91%. The question is really this, that if you have 91 to 94% cure rates, as you were saying, for your techniques, then that's pretty good. I mean, what are we aiming for, 100%?
If you want to have 100% or 91 is okay. I have another one.
Okay. Actually, in our department, actually, our boss was very critical. So we should keep a very low complication rate. So actually, I think it's better for us because we can think differently, use different methods to treat the AVMs. So actually, we learned a lot from Jack and Salu and Chivan. You all visited our department and presented some live case. And comparing their series, our cure rate by single embolization is quite low. But the totally, the complication rate was kept very, very low. Yeah. Use combined treatment.
You know, one of the reasons why I didn't participate to the Aruba study was just because when I looked at my complication rate, I could not imagine that I will continue to treat asymptomatic aneurysm. You know, at that time, 3% deaths and 10% permanent neurological deficit for an asymptomatic AVM, no, it's not acceptable. So that's the reason why I decided to not participate to the Aruba study. And before Aruba came, I decided to stop treating asymptomatic AVM. And today we treat it in a much better way compared to 20 years or 15 years ago. But I cannot change. You know, it's not that dramatic. This AVM disease is not that dramatic according to time. It's not an aneurysm.
Even grade 1 or 2. I mean, this is the biggest problem. Even a patient has a grade 1 or 2 AVM. Shouldn't we think about treating it?
I agree. We should seek it out, but we have no proof that it's better. So that's the reason why I need a study which is randomized and stratified. You take frontal AVM, grade 1 and 2, and you randomize. You take Hollandic AVM, grade 1 and 2, and you randomize. This is the only way to understand.
But randomize against what? Natural history.
Yeah, against.
But natural history, a lifelong business. This is the problem.
If you have 10 years, you have already a good view of what's happening. It makes a big difference when you discover an AVM when you are 15 years old or when you are 60.
Definitely.
And according to what we know about the natural history, the older you are, the more risk to get a bleed. But you know, if you treat a 15-year-old boy and you got a complication, he will be going for 50 years or 70 years with the complication. That's a big concern.
Micro. I have a question. I liked your study, your talk very much, and I think this is wonderful that you have all the three modalities in the same hospital. And not only three, but you have different types of stuff. Fully agree. Radiation is beautiful. My question is, when you evaluate the AVM, the first one, Virgin, you have a conference with all the doctors involved, like radiologists, because neurosurgeon, you have neurosurgeons who do the radiation. Also, neurosurgeons do the angiogram, or it's radiologists who do the angiogram. If they are radiologists, do you involve all the three specialties to discuss what?
Modality team. So actually, I'm doing just Ricardo know. I am doing both the open surgery and the interventional treatment. Actually, a long history. After Salu come to Huashan, it's maybe 16 years ago. Yeah, and actually, I'm also doing the open surgery for resection, and my colleague is just at the same floor. He has a cyber knife and the gum knife. He is a specialist. So when we have the AVM, we will discuss where we should embolize at first stage, then he will treat the radio surgery. Yeah.
But I think the question was, you have a discussion between everybody, doing gamma knife, doing surgery, doing endovascular.
Yeah.
But all those guys belong to the neurosurgical department.
Yes, yes.
So this is the problem.
Yeah.
You know? It's like the cardiologist. You know, they organize a show for the benefit of the organizer. And this is a big concern. The cardiologists manage everything. Angiogram, diagnosis, treatment, indication. Who is competing with that? Nobody. Nobody.
But normally,
but it doesn't make
too
much difference, because you know, if you look at the evolution of cardiology, cardiology has dramatically evolved. So I don't know. I'm sorry, but it's the same with politics.
Yeah.
You know, you have big democracies, and look at where democracies goes. You have countries with less democratic environment, like yours, like others, and the evolution is dramatic. So where is the solution in between? It's complicated. Yeah. You know?
Let's go back to AVMs.
No. We are not going to detail. We are not going to discuss politics. But it's exactly the same thing. It's exactly the same thing. Yeah.
AVM is way simpler than politics.
So I agree with Jack, because you mentioned you do both open and but you are surgeon. So is there any radiologist in this big hospital? And they do the angiogram, or you do the angiogram yourself? Because, but what is your basic profession? Neurosurgeon or radiologist?
Actually, maybe I'm neurosurgeon.
But you were trained from the beginning. It's like neurosurgeon. Yeah.
Actually, I'm doing both. Because I have one team. Yeah.
60, 70 years ago, the neurosurgeons puncture the carotid, push the dye, and they perform the angiogram also. Yes. And then some radiologists said that we could do it better. And this is why we took over this, because we had more practical skills. So this is why I asked. And sorry. There is also another issue, because I got in my hospital a young patient, a young lady living in Italy. And she came with a cerebral bleeding for 10 days ago, quite big. And in the report, there was written that she was treated by radiation therapy by cyberknife a year ago. I went and talked to the relative. I had to treat, because the surgeon wanted to evacuate the hematoma. I had to treat the patient. Then I went to the relatives and asked if they have any images, and they had lots of CD-ROMs and DVDs. So I collected everything and checked. The original angiogram a year before, or 1.5 years ago, 6 months before the radiosurgery, showed a big venous aneurysm, which was not visible on my angiogram. So this was obviously the ruptured site. So the people who went through the images, they chose radiation therapy obviously a lady, I'm 28 years old with a big venous aneurysm. That was very risky point. This is why I wanted to tell because obviously there was no one who pointed out this risk that this should not be treated by radiation because the result takes 3 years to get. So this was my point.
Yes, I mentioned that we will analyze angio architecture at first. Then we will treat the risk factors at first, including the drainage stenosis and the aneurysms and the venous ectasia. Yeah, we will treat that at first. Then we will send them to the Ghana hospital.